Good afternoon.
Hi.
Morning.
Hi.
Your country morning. It's morning.
Yeah, it's really morning. It's really morning, and I'm
Yes.
sorry you can see me in this way, but I'm outside with the family. But still, I wanted really to be with you this morning for me, this afternoon for you.
Oh yeah. Is it had a good good channel tonight?
Yeah, I'm having a good journey. Actually, I'm outside here with the family, and you know, we're having a little trip because Monday and Tuesday is holiday here. So
Oh,
we're
why you
having 4
don't
days.
why you don't come to Vietnam to visit?
Whenever you want, I will be very interested to come. I know that you have a lot to teach me more than what I can give it to you, and definitely I think you have a great country, great land. So whenever you want, really, I would love to come
tomorrow.
No, tomorrow is a little bit difficult. Tomorrow is a little bit difficult, but in the future for sure.
Thank you very much about you. You give your
yeah,
experience. Experience.
Yeah. Today you will see a couple of talks. One is more general about concept why to replace a radial head, and the second one is more technical on how to implant it. But definitely there are a lot of topics. I really love the presentation I heard before. Actually, I wanted eventually in the future to talk to you about my experience on minor instability of the lateral elbow. I've been studying that for the last 10 years. And we're actually treating most of our elbows with arthroscopic treatments and plications of the lateral collateral ligament, because I think that's one of the main causes of a lateral elbow pain.
Okay.
Whenever you want, we can talk about that.
Yeah, thank you. Let's go. Thank you. You begin to give your lecture. Thank you.
Yeah, now we're gonna start the lecture. You have my videos, so you can see the lecture, and later we can talk a bit. Thank you so much again.
Thank you so much for the invitation. Today we are here talking about radial head replacement. And during the day, you will see two presentations. This one is going to be more on general principles on why and how to do a radial head replacement. And then you will see some more technical tips and tricks on how to generally implant a radial head, and more specifically about a specific model of radial head. So why not to resect? I personally don't like it, but in general, there is a reason why not to resect, because there are several mechanical complications and in general long-term complications. There can be early complications or late complications. And if you think about the radial head with what is called the Greek temple model, you immediately understand, and you can see here nicely on the right, that both the ulna and the radius contribute to the stability of the elbow and the arm. In particular, the medial side of the ulna and the radius. And in general, the indication for radial head replacement is to have more than 3 fragments. Because, I mean, if you have more than 3 fragments, you understand there is no more clear surface in which the capitellum can load. And as on the radial head, approximately 60% of the load of the elbow passes, this is a very good indication for replacing the radial head. Of course, in terms of indication, you can have a simple or a complex elbow dislocation. And when I say simple, I indicate the dislocation without fractures. Complex is a complex dislocation, means that you have a fractured dislocation of the radius. And there is a role for LCL, definitely. The stability of the lateral collateral ligament is fundamental. Here you can see nicely how you nicely see the 3 bands of the ligaments that stabilize a radial head, that are the ulnar band or LUCL, the radial band, and the annular ligament. Of course, extra-articularly, you also have some dynamic stabilizers that are mainly tendons, And ECRB is one of them. ECRB is just parallel and extraarticular respect to the radial band. And this, I invite you to read this study, very nice, written by Cohen and other authors on 2010 on Journal of Shoulder and Elbow Surgery, in which the role of ECRB tendon and the anatomy of ECRB tendon is very well depicted. In terms of the mechanism by which you generate the fracture of the elbow, we do know nicely the mechanism of posterolateral rotatory instability. That probably is not a pure mechanism. In general, is associated together with some degrees of varus and valgus. But the idea that the main element around which the whole forearm rotates is the MCL is correct. So the MCL is the pivot and the whole forearm rotates. And this way, you dislocate progressively your elbow or the elbow of the patient with a mechanism in which there is an avulsion from the lateral collateral ligament from the capitellum. Here we have also a model, a video model, in which you nicely see what happens during the mechanism of dislocation, and the radial head comes out posteriorly and you obtain the dislocation. Assuming there are several degrees of laxity, the radial head can be fractured because there is a mechanism by which it impinges together against the posterior cortex of the capitellum and you have a fracture. If it's a small fracture, it's just an anterior fragment of the radial head. If it's a major fracture, it's going to be of the whole radial head. Of course, if it's a small fragment, you can eventually not even fix it or fix it. The more the dimension of the radial head is greater, and the more you need either to fix it or to replace it. So you perfectly understand that the role of LCL and dislocation goes from a simple dislocation to a radial head fracture to a terrible triad with the same mechanism. And this is very interesting to know and to recognize. Of course, there are complications you can have that are valgus recurrence instability in case there is an association with the MCL, and in case you have a completely different patterns, and you can have a PLRI because there is not a recognized LCL lesion, or you can have persistent instability in case of associated coronoid and LCL, or you can go to an extensor that is a vertical instability of the whole forearm. And on the other side, you have delayed complications because you can have a cubitus virus that can create a tardy MCL elongation, can have a medial and posterior drift of the proximal radius, and you can have other secondary complications that you can see here very nicely in the slides, or you can have HO formations that can be typical of the humeral joint. There are several models you can use in terms of prostheses. The first ones were just covers of the radial stump to prevent heterotopic ossifications. The more we go on and the more there are several designs that can be different in terms of stem, can be long, intermediate, short. In terms of fixation, can be a loose fit or it can be a press fit. It can be cemented, or it can work with an ingrow, and the head can be anatomic, oval, round, or bipolar. And those are the three models you can see nicely in this slide: bipolar, anatomic, and the spacer. Those are the results with anatomic press fit. As you can see, there are very good results with very low complication rate, even if there is some stress shielding that you can have in anatomic press fit. Bipolar cases, these are the results. Again, very good in mainly all of them. Same with spacer. So the literature doesn't let us thinking of a superiority of one with respect to the other model, But definitely what we do have is that radiolucency in a spacer is higher in terms of percentage respect to the other models, but because of course there is no integration of these procedures. So going into reviews, you can see that there is no support for one type of radial head over another one, apart from the ones in silicon that has been proven to be completely insufficient biomechanically. Let's talk for a second about the type of approach. You can actually access the radial head with two great intervals. One is the Coker and the other one is the Kaplan interval. The Coker interval is more posterior, so in general it's more at risk than LUCL, but you have more extension posteriorly. I would say that with this interval that can be extended more nicely with respect to the Kaplan interval, you can easily arrive on the capitellum and also repairing the LCL, because the base of all the radial head prosthesis is to repair the LCL at the humerus side. If you don't repair the LCL, that prosthesis is going to have a very poor outcome with risk to being unstable. So here there is another way and another, as you can see here, there are images, very nice, on how to expose the radial head. So the big difference to me is the LCL detached or not? If it's detached, my suggestion is to dislocate posteriorly or subluxate posterolaterally the radial head with a normal retractor posteriorly and anteriorly. On the anterior side, try not to be too aggressive because the nerve is very close, and work on the stem to implant your prosthesis. If the LCL is intact, I suggest you not to do anything on the LCL, and the space to work in is more limited, and you cannot dislocate, of course, the radial head. But as soon as you remove the pieces, the fragments of the radial head, it's going to be very easy to see the spaces and to work on the radial head. Another very nice step that you can do at this point is to see nicely the sigmoid notch, because again, this is something you will see nicely later, checking or before checking the presentation we have prepared on sawbone. The length of the radial head is critical, and you don't want to be implanting a prosthesis in overstuffing. So please refer to bony landmarks, both in terms of height. You want to have something that, a prosthesis that is coaxial with the medial, with the lateral side of the coronoid and not protruding that level. And at the same time, in terms of sizing, you want to size it based on bony landmark. You don't want to size your prosthesis because of creating a temporary stiffness because the prosthesis is bigger, because that is going to be a painful prosthesis by definition. And at the end, please do reconstruct the LCL. Do that with transosseous sutures, do that with a suture, dedicated suture anchor, I don't mind, but the result should be something like the one you see on the right side here, very nicely, a prosthesis that is completely collinear with the medial side of the coronoid and the sigmoid notch, not protruding medial to lateral, and the LCL completely and nicely reconstructed. So advantages and disadvantages of the Coker and Kaplan interval or modified Kaplan are the ones that we have been talking about. Wrightington or Boyd approach is a very, very nice approach you can use if you are addressing a major fracture in which you have a terrible triad. And so I suggest you to consider to use this approach in which basically you are exposing the posterolateral aspect of the olecranon, making a flap in which the anconeus muscle remains laterally and skeletonize the lateral side of the olecranon. This way you arrive, if you can dislocate slightly posterolaterally, to see very nicely the radial head. You can work from that side, and you can also see the tip of the coronoid also if you have to repair or to fix it. This is a very useful approach. In general, I do that in a lateral decubitus positioning with the elbow that is upside down and not on a table like you would operate a hand. but you can, of course, position the patient in the position you like most. This is the X-ray of the previous patient in which we fixed the ulna, and at the same time, we did a replacement of the radial head. Of course, this is a complex instability with the ulnar transolecranon fracture and the radial head, and this is the final construct. You can do everything in the same session from the posterolateral bowed approach. This, I think, is a great advantage. So in terms of results, it's not the prosthesis itself, but the results are related to the extent of the injury and severity of the injury. And you have to treat all the associated injuries. So radial head is an instrument, radial head prosthesis, sorry, it's an instrument when you deal with a complex radial head fracture together with other associated injuries. And please avoid other complications that can be, of course, limited with a more careful technique. Sizing is critical. As I was telling you before, you want to have a correct radial head replacement. And so both in the horizontal plane, you want to size it such that it's not too big, too wide, and it's not too small. So when you take the radial head in your hands, you will see that there is a sigmoid portion that is the outer portion that works specifically for the proximal radioulnar joint. And then there is an inner portion that you can nicely draw over the radial head. That is the one that is articulating with the capitellum. Radial head replacement, the radial head prosthesis is a circle by definition. So it's something that is in between these two measures. So the wider or bigger diameter of the sigmoid portion and the diameter of the inner circle that is going to articulate with the humerus. In terms of height, again, you want to measure it based on bony landmarks. So you want to see nicely, point indicated with the arrow number 2. So this is the most superior portion of the sigmoid notch. And that's your reference. You don't want to size the height of your replacement based on soft tissues. Complications, of course, you are at risk of overstuffing, loosening, stress shielding, and nerve lesion. But of course, you can limit all of them. By definition, over-tensioning the radial column is a problem because, of course, you will have chondral erosion. And remember that your radial head replacement is an endoprosthesis, it's not a total. So, of course, you can have a wear of the cartilage there. So this, for example, is a case in which there is an over-tensioning of the radial head, and that you can see in figure in the lowest and right part of the screen. On the other portion, instead, you have a correct positioning. Of course, long prostheses, especially in situations in which you have an axial instability, like an axial prosthesis, are at great risk to be painful and to tend to dislocate posteriorly. So, or on the other side, you can have a short prosthesis like you see here, in which there is no load on the radial head, and this is basically, it's not interesting to have a prosthesis like this because it's not acting as a support for the lateral component of the humerus. Heterotopic ossifications can be a complication. You know that the way to classify the mass can be done in 4 grades based on this very small publication. The number 1 is the ones that are just small clouds in the soft tissues. Number 4 is a bridge and can create an ankylosis. Number 2 and 3 are obstacles to flexion. Losing or stress shielding can be measured by Grewal areas and classify the radial lucencies based on these areas. So you can have none, mild, moderate, or severe. Nerve lesions are very infrequent, but of course you have to know that PIN is just anterior to the radial head. So not maybe direct injuries based on tractions, on direct injuries, but tractions based on nominal retractors or exposures that is not adequate can create compressions of the PIN that can create problems in the posterior, in the post-op phase. Thank you so much for this time.
Thank you so much for your presentation. Very interesting presentation. And with you,
Thank you so much.
A very interesting journey with your family.
Thank you so much. If you have questions, or I don't know if you want to launch the second one or you're going to do later, but I'm available, of course, whenever, whatever you want to do.
Now is in your next, the second video.
Hi everyone, it's a pleasure for me to be here and to talk a bit about this wonderful prosthesis that in my practice has been a really revolutionary tool because it changed completely my practice. So I'm gonna say a few words about the prosthesis itself, something about the tray you're gonna receive when you implant it, and later on a couple of tricks on saw bones on how to implant and how to measure the dimension of the prosthesis itself. So when we talk about the prosthesis, for one, here are the pieces that are part of the prosthesis. Let's put it here. Here is the stem, and the stem has a very peculiar condition to be completely coated with T-por, this material that is very, very interesting under the point of view of integration within the bone. The bone likes a lot all this expansion that you can see here. And the other thing that I want to tell you is that by definition, when you're going to measure it and pass from the trial to the definite prosthesis, you will find that there is a very nice fit you will feel in your hands. Then there are the collar necks. And these ones are quite common and don't represent anything that is completely different from what is known in the market. Those collar necks can be mounted over the prosthesis when you do the operation. And in general, they give 10 degrees of freedom to the head that is free to move. The head itself is done in this way, as you can see. So there is some polyethylene, and there is a coverage here. It's golden coverage. It's not fully gold. Remember, don't try to steal it, but it's golden. And what is nice of this is that even in a lateral X-ray, you will see through the polyethylene, and if you have an associated coronoid fracture, you will see the coronoid from the lateral point of view. So you have the great advantage to see on the lateral X-ray your coronoid fracture reduced or with a screw that holds the fracture. So let's move for a second to the tray. So what you receive in your OR, apart from very standard introductor and broaches, as you can see here, and you will receive some trials and some spacers. These are the spacers that you have to insert, or you can insert at the very beginning of the procedure once you have resected the radial head to see the space that is left for the procedure itself. The beauty of this spacer is that you have a liner here that is done in nitinol, I think actually, but still I can definitely tell you that it's metal. And the beauty of this is that both in the lateral X-ray and in full extension with an AP view, you can see the occupational rate of the prosthesis itself. So you will see the height of the prosthesis and the dimension of the prosthesis itself in the higher portion. So this is completely overlapping. So it's very nice to understand at the very beginning what is going to be the height and what is going to be the medial to lateral volume and occupational index that you will have with your definite prosthesis. Of course, you have 3 sizes. Those are guided by colors, so that you know that changing color, you are increasing the dimension of the prosthesis itself. On the other side, on the stem that is going to be a trial, even in a secondary phase of the procedure, you can add this head that is going to reproduce the final construct. So I invite you to use it as well. Apart from this, all the rest are instruments to implant the prosthesis and also to test if the mechanism of blockage of the head into the stem has been working with this little fork. This is clearly a sawbone, and I'm going to explain you a couple of concepts on how to facilitate your work into the joint A and the sizing of the joint of the prosthesis B. Let's talk about sizing for a second. Let's say that you have your radial head here, and you all know that the radial head is not a perfect circle, but it's an oval. Even more precisely, when you replace the radial head, you are technically replacing 2 joints and not just one. The proximal radioulnar joint, in which it's fundamental to have a radial head that is an oval, because thanks to this oval shape, you have the radius, the center of the radius that got dislocated laterally in certain positions. As you can see here, the center of the radial head is more lateralized. When you go into pronation, the center of the radial head goes closer to the ulna. On the other side, you're replacing the vertical, the column, the lateral column. So you're replacing the radiocapitellar joint. And in this case, this is definitely less important to the sigmoid concept, because of course this doesn't change its shape. So, of course, you're going from an anatomical or a sigmoid radial head to something that is circular. It's a perfect circle. And of course, it's a balancing between the 2 joints that you have to replace. So my suggestion when you are replacing the joint is, by definition, not to take the external diameter of the radial head, in particular the longest one, because by definition you would use a very big prosthesis, or the prosthesis that is bigger than what you would like to use to replace just the lateral column. So what I suggest you is to, if you have one piece, of course if it's fractured it's different, to design the inner circle, so the inner portion of the cartilage that goes into contact with the capitellum. So you design the inner one, you design the external one or the smaller diameter one, and you probably want to take a dimension that is in between these 2. But by definition, I would not accept in my hands to replace a radial head using the biggest diameter, because it's going to be the biggest you can. The second test you can do is to take the prosthesis and to put it over the capitellum and to understand the amount of congruity that you have of the 2 and to have an idea of the dimension. The third one is to take the diameter or the dimension of the medial to lateral capitellum, and that's another very nice instrument. At these points, you have several measures that allow you to take your decision and to take an average of these ones, but if you have to decide, always tend to be undersized instead of oversized. Let's talk for a second about another concept that has how to size the height of the prosthesis. 2 or 3 concepts. First of all, never measure with the joint very open, eventually with the lateral collateral ligament that is completely avulsed, torn. You are on a table normally with brachial plexus anesthesia, so the joint is like this. So never try to measure in this way, and never use the height of the prosthesis to compensate a joint instability. That's a super important rules. If you do that, you're gonna have a stiff elbow, painful elbow, so please don't do that. So in terms of how to measure the height, I suggest you 2 ways. One is, let's take this model in which there is no radial head. First of all is, don't take at all any reference with the humerus. Just take the reference with the sigmoid notch, with the highest profile of the medial side of the proximal sigmoid notch. So you probably want to have something, I'm going to use this fork to indicate, that is going to arrive at this level. So to fill this gap, so completely independently from the height, from the contact with the humerus. And this gives you a reference. B, reduce the humerus, keep the humerus at 90 degrees of flexion, all 2 fingers or have your assistant pushing the ulna toward the humerus so that you are creating a stable construct independently from the varus valgus and the stress of the ligaments, and test this height in this position. That's a very good way. Third, clinically, you want to have your elbow going in full extension without problems. If it doesn't go to full extension, but it blocks at 10, 15 degrees, for sure that's a stiff elbow. So you want to measure your height based on bony landmarks and not on the stability of the joint. Once you have done that and you have finished your operation, implanted your replacement, then it's another fundamental step to reconstruct all the lateral collateral complex and ligamentous complex with suture anchors, bone tendons, whatever you want, but it's part of the procedure itself to reconstruct the ligaments. You cannot replace the radial head without reconstructing the ligaments if they are torn. That's crucial. I want to share with you a couple of concepts on how to expose correctly the radius and the joint. First of all, when you are approaching the elbow, it's completely different if the LCL is torn or the LCL is intact in its ulnar band on the humeral insertion. In the vast majority of time, it's going to be torn. So you will have a great access to the joint, but you have to recognize it. I wouldn't be scared, and this is something I normally do in my practice, to go up following the humerus on the supracondylar region to detach the capsule here. The capsule here is not very important in terms of stability of the joint, but when you expose the capsule here and you flex a bit the joint, you will arrive to see very nicely also the ulnar side, the radial side of the ulna. So flex and expose also the capsule here to obtain a lot of vision. Be certain and to recognize if the LCL is torn or not, because if it's torn, you will have to reinsert at the end of the procedure. C, the way in which you gain access to the radius is to extend, supinate, and dislocate posterolaterally the radius. In general, what I do, I put an omen in between the 2 joints here, and an omen here. So an omen posterior, an omen in between the joints, so that my radial head, my radius goes posterior and lateral to obtain space, and so I can work with my broaches almost straight away. So to give you an example, I'm going to be in a position like this. I'm going to insert, pretending that this is an omen retractor. I would use my retractor in this position, 30 degrees, and the radius is going to be like there. In this way, my broaches are going to work almost in a straight direction respect to the radius, because you have the radius that is dislocated, posterior, posterolateral, and the broaches, I'm sorry for this, and the broaches are gonna work in this way. Once you're done, you reduce the elbow. So don't feel scared of dislocating also the humeral joint, to dislocate it posteriorly. Once you're done, you reduce the joint, go at 90 degrees and check it. Check the stability and check how it is. Remember always that the joint is more stable in pronation than in supination. So that, of course, even if you don't have any ligaments, but you pretend to test the stability at 90 degrees in pronation, that prosthesis is never going to come out. If you really want to test the stability of the system, go in same extension, 30, 40 degrees, full supination, and below the radial head posteriorly. And in this way, you will understand that you need the ligament to be reattached. Otherwise, everything is going to be unstable. So it's the prosthesis itself is an easy prosthesis to implant. The difficult part is to understand the whole joint and the soft tissues that stay around, that have to be completely considered and resutured at the end. Thank you so much for your attention. Thanks to Adler for this possibility of this very nice prosthesis. Thank you to all my Vietnamese friends for these invitations.
Thank you so much for your experience on radial head replacement on the aspect of techniques. And now we next to the discussion. Tôi xin nói là một ít đây là cái nói về cái kỹ thuật, chủ yếu là phần kỹ thuật. Tôi cũng không phải là chuyên về cái này lắm, nhưng mà ông nói về chủ yếu về các cái phần kỹ thuật thôi. Về giải phẫu làm sao chúng ta phải nắm được cái giải phẫu trong lúc mổ đó, phải biết hiểu được cái chỏm quay nó như thế nào. Chỏm quay nó không phải là một cái hình tròn, mà nó là một cái hình oval với các cái đường kính ngang, đường kính trước sau nó rất là khác biệt. Cái thứ hai là khi mà mình mổ thì mình thử xoay đó để mình xác định cái vị trí nó vững nhất đó, thì là khi mà ở tư thế ngửa thì cái chỏm quay nó sẽ vững nhất, và ở đó thì cái đường kính chỏm ở trong ở ngoài thì nó lớn nhất, và đường kính ở phía trước phía sau thì nó nhỏ nhất. Và mình thử làm sao size nó chính xác ha, chứ không thể nếu mà mình size không chính xác mà mình đặt cái chỏm mà nó oversize á, thì kết quả nó sẽ không có tốt. Nói chung là rất là nhiều đặc tính kỹ thuật nữa ha, mà tôi cũng không thể nào mà nốt hết. Thì chút nữa cái phần thảo luận á, thì mọi người mình sẽ hỏi và để ông trả lời trong từng phần kỹ thuật ha. Thầy Khanh, thầy có nốt gì không thầy?
Thank you, Dr. Paolo Angelo. Yeah, you had a great presentation and sharing your techniques, radial head fracture, your radial head replacement. Okay, I had one question for you. How you can check the congruence when you put the radial head? This means sizing. Because when you check the rear radial head fracture had a lot of the physics. Yeah,
that's a very good question, actually, probably, because of course it's easier when you have an intact radial head and when you have several fractures. So first of all, the point is a couple of things. One is get an X-ray of the other side, because this gives you an idea of the dimension. B is try in your pieces to find out if you have at least in one piece a full radius. So you don't need that, because our mind look for the diameter, but honestly, you don't need the diameter, you need the radius. So if you, in one of the pieces you have a distance that is from the center to the lateral component, that's all you need for measuring, for understanding. Then you can start from that radius consider the wall circle, and then taking the trials and test it in the ways I showed in the presentation that I'm not going to repeat. But I think that's a very good question, honestly. And try to be small.
Okay, thank you. Ông nói rằng nhiều lúc mình nó gãy mà nát quá mà mình không có ráp lại các mảnh nhỏ, ráp lại thành một cái chỏm xung quanh một cái khối hoàn chỉnh á, thì ok, mình cũng có thể ráp những cái mảnh, có thể mình xác định cái đường kính thôi. Còn giả sử mà cái trường hợp mình ráp lại mà không được đường kính đi nữa thì mình chỉ cần xác định được tâm xoay, cái giống như một góc bánh á, góc bánh mình cắt ra, xác định được tâm xoay, xác định được bán kính, thì đó lúc đó mình có được cái diameter, cái đường kính, thì lúc đó mình sẽ chọn cái kích thước phù hợp. Còn mà giả sử trường hợp mình nát luôn thì chỉ còn cách mình xài cái đối bên. Nếu như mà mình có cái plan từ trước, mình dựng hình, mình đo kích cỡ để mình chọn cái phù hợp. Thank you so much.
Okay, thank you.
Thank you.
Continue the question. If the radial head is too communist, cannot to choose the exactly size. If your experience, you choose
Okay,
underside.
I underside.
You choose
I
underside
also
or oversize.
Okay, so let's say that I completely do not have a radial head. It's completely gone, lost. At that point, what I would do, I would start from measuring the diameter of the capitellum on the humerus. So measuring the capitellum, and I know that diameter is probably gonna match with the diameter of the inner circle of the radial head. So the circular component, not the sigmoid component, but the circular. So I know that that's my lowest possible measure of the implant. From that point, I would measure the distance, and this is difficult to project, but in general, what I would do, I would put a pin inside the canal of the radial head and measure the distance, assuming that that pin is completely centered in the canal, from the pin to the lateral side of the sigmoid notch. So that's another measure that I do, and I know that probably that's a diameter of the sigmoid of the a radius of the horizontal component of the procedure. So I use these two measures to start my thinking on how to measure the medial lateral dimension of the prosthesis. I think it's clear, is it?
Yeah, your answer make clearly. Okay, I can translate something. Thì thầy Khanh có hỏi là giả sử trường hợp mà nó nát quá, giống như mình nói không ráp được, hàng nó mất luôn đi. Cái trường hợp bệnh nhân ở tuyến dưới mà đã cắt rồi, cắt cái chỏm quay bỏ đi bởi vì nó nát quá, không có kết hợp xương được, mà không có điều kiện để thay khớp, thì giờ lên tuyến trên mình thì mình sẽ làm sao? Thì một cách là giống như mình nói dùng đối bên, nhưng mà cách đối với ông Dr. Paolo Arrigono á, thì ông sẽ dùng cái đường kính của cái chỏm con, có nghĩa là ông sẽ đo sao cho nó cái đường kính nó phù hợp nhất với cái chỏm con. Kết hợp theo nữa là mình biết rằng cái chỏm con nó không có ngoài chức năng mà hinge, cái nên là giữa là cái chỏm con với lại cái chỏm quay, mà nó còn liên quan tới cái đầu trên của xương trụ nữa, thì mình phải test cái gọi là lateral sigmoid á, cái khuyết sigma nhỏ gọi sigma bé, thì sao cho nó phù hợp để mà nó không bị cấn, nó giữ được cái chuyện mà gấp duỗi mà cộng với lại xoay nữa. Yeah.
Tôi xin bổ sung cái đoạn cũng tôi thấy quan trọng mà nãy giờ cũng chưa có ai nói trong cái bài giảng của ông Arrigono, tức là ông chia làm hai loại, là một loại là có mất vững và một loại không có mất vững. Trong trường hợp mà có mất vững thì mình chắc chắn mình phải tái tạo là sau đó, nhưng được cái ưu điểm là vì nó đã bị hỏng cái dây chằng bên ngoài rồi, cho nên là lúc mình vào thì cái lối vào nó rất là rộng mở, thuận lợi cho mình thao tác. Tuy nhiên là có một số trường hợp thì có một số phẫu thuật viên thì nghĩ rằng là khi nó bị mất vững vừa phải thì tôi cũng không cần tái tạo, mà tôi sẽ dùng cái cỡ to hơn để làm cho chặt hơn. Thì ông bảo cái đó là sai lầm, không bao giờ mình dùng cỡ to hơn để cho chặt hơn đấy, vì chắc chắn sau này sẽ gây đau. Cho nên cái mà sizing is critical, tức là đối với ông là cái chuyện mà lựa chọn cái kích cỡ của cái chỏm nhân tạo là cái quan trọng nhất trong cái cuộc mổ thay cái chỏm quay này. Mà tôi cũng nghĩ là như thế. Vì về kỹ thuật thì không có gì khó, chỉ có là ta chọn sao cái kích cỡ cho nó phù hợp nhất thì nó quyết định cái thắng lợi của cuộc mổ. So I'm explaining a little bit more about your remark with regards to the sizing of the prosthesis. Thank you.
Another question. Because I see you on the radio or 5 side, and the stem to you only have a 3 side.
No, the stem has more than
The
3
stem.
sizes.
Yeah, got 3 sides. I see. The side.
No, I don't mind. I mean, I size the stem based on the broaches and the press fit that I obtain, and I size the radial head in terms of medial to lateral, so dimension, as I said, in terms of height, as I said in the presentation. But I don't mind at all to have 2 different measures of the size and the prosthesis itself. It's completely 2 different measures, completely.
Okay, dynamic I have 1, 2, 3, 7 side dynamic of the stem, but the length of the stem I see 3 sides. So
yeah, I don't mind to go long or short on the stem. There is a okay, the very first times I was using this stem, I was scared as well to use about the integration, but you will see that there is a very, very nice press fit and integration. So I don't mind at all to have a short stem into the canal.
So
I'm just interested about the press fit.
Yeah, the stem you can down a little bit or up a little bit. It's okay. The stem into the bone.
Yeah, of course you want to have the superior aspect of the stem that is collinear with the resection, but I don't mind to go. Let's say that I've resected more stem because the fracture is like that. Yeah. I would implant my prosthetic stem a little bit lower in terms of AP view in X-ray, and I don't mind at all. I would gain that space with the height of the head and the neck, not with the stem.
Okay. Oh, thank you, sir.
Okay, thank you, Dr. Paolo Arrigono. I had one more question. The patient come with complete elbow fracture dislocation at your case illustration first presentation. This man had a complete radial head fracture, and proximal ulnar fracture. What the kind of you go? This means step by step. You reply first, or your position the proximal ulnar fracture first.
No, you want to do the ulna first. You want to do first for several reasons. One is because the ulna gives you the real reference of the length of the forearm. So you want to reestablish the length of the forearm. And the ulna gives you the length. Once you have done that, you have a clear reference that is secure on how you want to replace the radial head. But the radial head is going to be done later. What I normally change in my approach, if I have a proximal ulnar fracture that is associated with the head, is that my surgical approach is going to be posterior, and I'm going to arrive on the radial head from the Boyd approach, so from posterolateral, not from the Coker approach.
Thank you. Thank you, sir.
Could I have another question, and maybe the last one?
No, it's good. It's good. It means that you have a lot of
the journey with your family. So
yeah, definitely.
In terms of sizing of the prosthesis, you know, normally for other joints like the hip or knee, we usually do the templating before the operation. So would you do it at the routine? I mean that we take the X-ray for the contralateral side of the elbow as a reference. And we do the measuring according to that to estimate the size of the radial head prosthesis, or you just do it clinically, I mean intraoperatively. Thank you.
Honestly, I don't do in every case because I think there are two, in general, differences in between measures are a millimeter or two. So very small differences, no? You can go from 19 to 21, 22, depending on the size of the population, no? Diameter I'm talking about. When you do a contralateral X-ray, you are never sure of the distance and the quality of the projection that have been taken, even assuming that they are standardized. But a millimeter is an error you can leave in some passages of your measuring. So the quality of the X-ray, the standardization of the X-ray, the guy that goes there and measure it, that eventually is going to be your resident or maybe you're going to be yourself. And then once you are in the field, as I told you, it's always a compromise in between several measures you do. So you want to measure the capitellum, the pieces of the fracture, the height. So it's a compromise and you have to accept it. What I normally do instead is I take an X-ray every time I have implanted my trial. This is something I normally do because sometimes I think I'm correct and I take an X-ray and you realize that the X-ray with your trial in is completely, it's not acceptable. And this is a moment in which you can change the size. This is something I normally and routinely do while I'm doing surgery. So I do this surgery always with the possibility to get an X-ray intraoperatively.
And intraoperatively, in case when you have your sizing done and the company doesn't have the appropriate size, so how many millimeters would be acceptable to you? I mean, as a
honestly,
as a substitution.
I understand
real life.
Real life. That's a very good question because we always talk about general systems and then there is the real life. I admit that it never happened to me not to have the size, but A, I would be very angry with the company, first of all. B, I would probably go, I would probably undersize. I definitely, if I'm in the middle, I would undersize. I think I finish a lot of my operation with the smallest size, and I do eventually a good, even better reconstruction of the soft tissues around. So you want to close the soft tissues all around your prosthesis. For example, what I do in some cases of fracture dislocation in which there is a huge defect and a huge loss of ligament attachment is to put an anchor also in the posterior aspect of the capitellum very high. So in the cautery lesion, so you know where the radial head got posterior and dislocated, an impact on the posterior aspect of the capitellum, creating what is called, it's like an heel sacs of the elbow. So in that defect that is just higher than the cartilage, I would put a second anchor. So I would put an anchor that is posterior to anterior in that defect, and then an anchor in the isometric point on the lateral side. So I augment the amount of anchorage of soft tissues that I do. But definitely in terms of sizing, I would go smaller. Smaller with the right height. The height, I think, is important.
Smaller diameter, but same height, right? Yeah. Very good reply.
This is real life, you're right.
Yeah. Anh mới giải thích câu này luôn hay là để cháu?
Giải thích đi.
So I explain for my colleagues. Tôi có hỏi là bình thường thì mình mổ thay khớp khác, ví dụ như khớp háng là mình hay làm templating, tức là mình chụp cái hình X-quang tele để mình đo cái kích cỡ trước để mình có một cái dự báo trước về cái kích cỡ, vì mình biết là cái kích cỡ rất là quan trọng, đặc biệt là trong cái chỏm quay này mình thay mà sai cỡ là nó thất bại ngay, nó có thể quá chật hoặc là quá lỏng. Thì ông nói thường thì ông không làm thường quy, trong một số trường hợp đặc biệt, tại vì cái đó không đáng tin cậy, tức là nó chỉ cần sai 1-2 mm thì cũng đã là sai rồi, cho nên ông sẽ đo trong phòng mổ là chính bằng những cái phương pháp mà ông đã nói. Thế thì tôi hỏi câu tiếp theo là giả dụ trong phòng mổ mình đo xong thì công ty bảo là cỡ này em không có, đấy, thì bây giờ làm sao? Cho nên là trong đời thường đấy thì không hy vọng là IMD là không bị cái này. Thế thì phải cho mình đủ các cái cỡ từ số này đến số khác là nó một series liên hoàn chứ không phải nhảy cóc để cho nó giảm tồn kho. Trong cái đời thường thì ông bảo cái này là rất đời thường, và như thế thì tôi sẽ nổi điên lên với công ty và tôi sẽ khắc phục bằng cách là tôi sẽ undersize, là dùng một cái cỡ nhỏ hơn. Trong cỡ mà công ty có thì tôi ưu tiên là cỡ nhỏ, vì lý do là nếu mình dùng cỡ to thì nó sẽ cấn gây đau, còn cỡ nhỏ thì ông sẽ khắc phục bằng bù trừ bằng cách là ông sẽ khâu bao khớp lại cho nó chặt hơn so với bình thường. Xin hết, anh Khanh điều hành.
I see you have the head radio head replacement, the same of the bipolar, but you know the total, the capitellum and the radio head is the same type. You replace total. The radio head.
I've tried.
and the
I've done this
capitellum.
experience.
Yeah, because the capitellum is now damaged too.
Okay, this I know what you're talking about. These specific implant that I've been talking about doesn't have a capitellum, but there have been experiences out there with the total, so capitellum plus radial head. I think that the solution is very interesting, that we still have to study a bit, because I think it's a very unstable construct, and we have to work a lot on soft tissue reconstruction to have a very good implant. What I would aim for, and eventually is going to be one of the future for this company or other companies, to do a more congruent radial head. So instead of having a flat or almost flat prosthesis on the radial head side, having a more congruent one so that it is more stable on the capitellum. Did I answer you?
But in the future, I think it had the fracture, the radial head and the capitellum is damaged. You must total the capitellum and the radial head replacement in the same time. The same of the, of the hip.
Definitely, it's going to be it has been something done in the past. There have been models of, unfortunately, they have been removed from the market because there were very few numbers.
Yeah.
But the future is to have 3D printed models, so custom-made models that are done specifically on the patient. I'm sure this is the future. The 3D printing technology is changing the world in a lot of sectors, and is going to change the world also in our sector. If it's okay, do you have other questions?
Okay, today is okay, but tomorrow tomorrow is not okay. It's not okay. Thank you very much. Thank you, sir.
Thank you so much. Any questions?